Okay, perfect. So I am kind of looking down at my phone here. I have some notes to make sure I'm highlighting all of Dr. Esther's wonderful achievements because he is quite accomplished. So for those of you who don't know, Dr. Esther is one of the pediatric pulmonologists at the UNC Pediatric CF Center in Chapel Hill. And just a little bit about him. He got his MD and PhD from Emory in 1998, and then completed a pediatric residency followed by pulmonary fellowship at UNC in Chapel Hill, where he was able to stay on as faculty starting in 2004, where he's been able to provide care since then to children with cystic fibrosis, as well as other respiratory diseases, all the while maintaining an active research lab where he does research, and I'm going to not pronounce this correctly, but spectrometric metabolism. It sounds very impressive, and I don't really want to, I'm going to mess it up. But anyway, this has given him the opportunity to do lots of research to develop an understanding of disease-related pathways, respiratory diseases such as CF and asthma and COPD. And his research has been published in over 90 scientific publications, which is pretty impressive. So we're really lucky to have Dr. Esther give us his time this evening. I'm really excited to hear what updates you have to share. So thank you, Dr. Esther. I'm going to mute myself and please take it away.
Oh, thank you. Can everyone hear me okay? Am I coming through on my mic? Great.
Yeah.
So I've been doing this for over 20 years, and in all that time, I don't think I've ever seen as many changes over a short time span in terms of care of CF that I have over the past few years. So much of what I've learned is no longer relevant. So we'll see. I will be giving the update on CF, really based largely on some slides that I semi-stole from CFF presentations. And what I've done is put together a relatively short presentation that goes over a lot of the highlights from NACFC, with the idea that we could do that. And then I would love to take questions either during the presentation or afterwards about some specific areas of research that might be of interest to you or your family. So. This really has been an enormous change in terms of how we manage children and adults with CF. And even before the newest modulators, we were having great improvements with people with CF able to live healthier and healthier lives. In the past 20 years, been a threefold increase in the number of people married or living together, and a almost fourfold increase in the number of people with a college degree. And you can see lung function percent predicted. With 100% being average or normal, a lot of our children now have normal or near normal lung function, despite the fact that they have CF. And this is kind of one of the favorite things. I've been actually saying something along these lines for for many years. But if you go back to 1955, which I think was the year that the CF Foundation was founded, and CF was just recently being recognized as disease, if you happen to have a child with CF, you would actually be fortunate if that child lived long enough to enter elementary school. And then today, what I tell my families is, if you have a child with CF, you're probably going to be seeing your grandchildren off to elementary school. So it's just a sea change in how we're approaching kids with new diagnoses of CF. And this is one example of how more and more people with CF are having families of their own. So you can see in 2020, the number of pregnancies among moms with CF more than doubled, almost tripled, really. So that's really been a huge change. And of course, a lot of that is related to Trikafta. So introduction of Trikafta has really changed the lives of many people with CF. People are gaining weight, they're avoiding hospitalizations, they can smell. They didn't even realize they couldn't smell before, but because of their sinus disease, that's gotten better now. They can smell coffee. And we have all kinds of modulators now. So for example, ivacaftor or Kalydeco is now available down to 4 months of age. So I actually just put a baby on Kalydeco, or Cambi down to 1 year of age. Trikafta is right now 6 and up, but the data from the 2 to 5 year old study was submitted to FDA in November. So we're just now probably a matter of time before we have that approved down to age 2. And then it'll get younger and younger as we can do more and more clinical studies. And then Symdeko, which is not used as widely anymore, but still available for those 6 and up. But it's not necessarily all perfect. So we know from studies of ivacaftor, which we've had that for a much longer time, and we view that similar to Trikafta in the sense that it's what we call highly effective modulator therapy. In other words, the patients that are on ivacaftor generally do much, much better than they did before. But we still see that over the long term, kids and adults who are on ivacaftor still have some lung function decline, and it's probably a little bit greater if you started off better, so you had more to lose, and so the slope's a little higher. So it's helping. The early data with Trikafta actually seem to be showing that you don't see as much of a lung function decline, but one of the complications to that is that Trikafta was introduced right before the pandemic started. And with the pandemic and quarantine, many fewer viral infections. And so pretty much everyone with CF did better in the pandemic, regardless of whether you were on modulators or not. So it's really hard to know what the long-term progression is going to be. So overall, I think the feeling is that modulators are very, very helpful, but they're not really a cure. And then, of course, modulators are not for everybody. So about 94% of the population with CF will have a modulator eligible genotype, so at least one F508del or one of these other mutations. But that leaves 6% that have other types of mutations, nonsense, splice, frameshift, whatever. And then there's a subset of the patients that may be modulator eligible that simply can't tolerate the medication. So there's all kinds of side effects in terms of the liver, mental health, other things of that nature that make it difficult for some people to stay on Trikafta, even if they can take it. So there's a population out there that aren't really being served by the current medications, and they really need to be a focus. So these are the sorts of things that the foundation and other people that are doing CF research are really feeling like we need to focus upon. So we need to understand better what CF disease is like on modulator therapy. So what are the risk factors for disease progression? Are you still getting infected? And if so, how and with what organisms, and how should we treat? And then what about other problems that may crop up with people as they live longer and longer with CF? So GI issues, diabetes, mental health issues. And then, of course, the big thing is that we need new therapies for people who aren't modulator eligible. So if you can't take ETI or one of these other really highly effective drugs, we need something to be able to really treat you and ultimately try to get towards a cure. So there's a lot of multi-center studies going on. We don't have data yet back from all of them. I will talk about a couple of these, Simplify and Promise, where data was reported out at the NACFC. But it's, there's thousands and thousands of people with CF that are enrolled in these clinical trials. And one that I am particularly interested in is this Mayflower study, which is actually studying the role of pregnancy and childbirth for moms with CF that are on ETI or Trikafta. So we have a little bit of a role in that in terms of measuring drugs using some techniques we've developed in the lab. But lots and lots going on, and a lot of information that's coming out now and will be coming out in the future. So this was something that I think many of you probably are familiar with Promise. So Promise was a sort of what they call a real world study. So the idea was once Trikafta was approved, we were going to enroll people in a trial and actually look at their effect of starting medications in a variety of different parameters. So I put real world in quotes because the subjects in this were still in a clinical trial. So, and that people in a clinical trial are always a little bit different from the population as a whole, but it still is this isn't the original clinical trial. This is sort of saying, all right, it's been approved. Let's see what happens to you when we start these medications. And what's really reassuring and really great to see is that the people who started Trikafta after approval kind of did about the same as what we saw in the clinical trial. So and you have to remember, in clinical trial, people are being really closely monitored, and sometimes they do better just by the fact they're in a clinical trial and they know someone's like really checking after them all the time. But what we saw was a change in lung function. So this is percent predicted FEV1, and it went up in everybody that was treated, and it varied depending. So the people who hadn't been on any modulator therapy before got up to 11, 12, 13% increase on average, which is very similar to what was seen in the clinical trial. If you had been on Symdeko before, your increase was a little bit less, but that probably means your total increase, because you usually get about 3 to 4% increase on average. The Symdeko was similar. And even people on ivacaftor, which is actually a very effective therapy, still saw a bump. Not as great, but that's because they were already seeing a lot of modulator benefit. Similar things with sweat chloride, which we use as sort of a marker of whether the modulators are working. Sweat chlorides are dropping substantially, often into the normal range or near normal range. And then the CFQR is a very commonly used measure of self-reported health. And so the R is the respiratory domain. So again, patients were reporting that they were feeling better, less cough, fewer exacerbations. And then what's not I didn't show this graph, but also BMI, so weight and everything went up as well. So really very reassuring, very good to see that the data after approval looks very similar to what we saw in the clinical trial. And these medications really work. And of course, anecdotally, we've seen that again and again and again in clinic. Then there was another study that was really interesting to me called Simplify. And so I won't speak for any of your family members or loved ones with CF, but I know a lot of kids in my clinic have kind of stopped doing some of their therapies because they feel so good. And so this was a study to see if that was okay or what we were losing if you did that. So they took people with CF who were on either pulmozyme or hypertonic saline. You could actually be on both, but they picked one to actually study. And then they randomized you to either stop or to continue that inhaled therapy, and then tested your lung function again at 6 weeks. And they picked 6 weeks because a shorter trial is easier to do. And there was a lot of data suggesting if you were going to benefit from these medications, it was within 2 to 4 weeks. And so if we waited 6 weeks, we probably knew whether or not things were changing. And they decided that a 3% change in FEV1 would be significant. So that's what they call the non-inferiority margin, meaning that if a change is less than 3%, they consider that to be roughly equivalent. But what you can see here is actually, it didn't matter what you did. Didn't matter whether you stayed on hypertonic or stopped it. It didn't matter whether you stayed on pulmozyme or stopped it. Your lung function was pretty much exactly the same at 6 weeks. Not even sort of hints that things were changing. One graph that I'm not showing in this slide deck, but that they showed at the meeting, was that actually people on pulmozyme maybe did a little worse if they stayed on pulmozyme versus stopping in some measures, not in lung function. But so really kind of some actual evidence suggesting that if you are on Trikafta and on pulmozyme, you may be able to stop it, or hypertonic saline may be able to stop it. Now, one caveat to this is that these were all people with pretty good lung function. So they limited the trial to people with FEV1s of 70% or above. They had to be very compliant with their inhaled therapies. I guess it kind of goes without saying, if you weren't really doing it before and you stop it, it's not going to make much difference. And these were all kids and adults that were doing their airway clearance. Like 95% of them were doing their airway clearance regularly. So, which is not always the case, at least in my anecdotal experience. So they may not apply if you happen to be an individual with lower lung function or sicker. We don't know for sure that these trial results would apply to you, and I'd be a little more hesitant to recommend stopping a therapy. But it is good news that maybe we can start peeling back on some of these treatments for those with CF. All right, so what about those eligible for modulators? Sorry for the reference that dates me. Many of you will get it. If not, you can ask your parents. And just a warning here. So I'm going to talk a lot about some of the new therapies for specific mutations. And in order to understand what's going on here, you have to go back to your high school biology about gene transcription and all kinds of stuff like that. So if this was not your thing and you just barely managed to get through high school biology, this would be a good time to go get a cup of coffee or something. So here's the basics. You don't have to understand all of it, but you just basically have to understand there's a gene. It's got things called introns and exons. The exons are where all the good information is. The introns are sort of what they call junk. They're not really junk, but people call it that, and it sort of makes it easier to understand. And so you transcribe that DNA into an RNA, then you have a process called splicing that gets rid of all the introns. And then you have a process called translation, where the mRNA becomes an amino acid or is translated into an amino acid chain. And then that amino acid chain has to fold up into the protein that actually does the job. And so there are all kinds of mutations in the CFTR gene that can do different things. So sometimes you just delete the gene. Obviously, that is a problem. You could, in theory, have ones in promoters. I'm not familiar with too many promoter mutations, so I didn't have any examples to put down here. But going down, there's a lot of very common mutations that interfere with these. So there's splicing, so you don't get those introns and exons outright. There are nonsense mutations where you have a mutation that tells the machinery inappropriately to stop the translation process, or a frame shift that kind of messes up the code. And then you have folding where the protein doesn't fold right, or activity mutations where it just doesn't function right. And the important part to recognize here is that the modulators all really work down here. So they're going to work on proteins that either don't fold right or don't have the right activity. They're not really any good for the most part on the mutations up here. It's a little more complicated than that, but as a first pass, that's true. And while these, so F508del, very common mutation, so a lot of people have these mutations, there's a ton of mutations that modulators just are never going to be good for. So I'm going to talk a little bit about some of the therapies that are being developed for splicing and nonsense mutations. So nonsense mutations, so to go into this a little more detail, so you have your mRNA, you have sort of a start and a stop. So these are codes in the RNA that tell the body, all right, you're going to start your amino acid chain here, you're going to stop it there. So what a nonsense mutation is you develop what we call a premature termination codon. So it's a stop codon that comes too early. It's not supposed to be there. And so what winds up happening is your amino acid chain stops really early and you don't get the full length. You get a much smaller CFTR molecule, and it's almost always non-functional. So it just doesn't work. It doesn't have enough there to actually do what it wants to do. And so what the therapies for this are called read-through agents. And so they actually come down here and they block that premature stop codon, and they allow the amino acid chain to kind of read all the way through. And so now you get a full-length CFTR and hopefully one that's more functional. And so this has been something we've had read-through agents actually for a long time. And in fact, many of you may remember there was a therapeutic trial of one called Adalurin that was done around 2014, 2016. And while it was safe, it just didn't really work. So it didn't actually help or make CF any better. So what were the problems? So there were actually probably several problems with this medication for CF. One was it just wasn't effective enough. So the read-through wasn't sufficient. And in fact, there's a lot of different ways that you can affect read-through. So one of the strategies to try to overcome that is to use maybe multiple agents together to get more read-through than you can from any single drug. There's this phenomenon where if you have one of those premature stop codons, the body knows that that's not right. And so it actually goes ahead and just tries to destroy that mRNA. It's called nonsense-mediated decay. And so there are inhibitors that block that process that may allow that RNA to stick around a little longer and actually work. And then the other problem is that when you do these read-throughs, it puts an amino acid in where there would otherwise be a stop, but it doesn't necessarily put the right one in. It may be one that's not supposed to be there. And so you wind up getting effectively a mutated CFTR, but so sometimes you can put modulators in, and actually that will help because you'll have CFTR, which you didn't have before, but it's not functional. So the modulators can do something for you. And then there's tRNA-based therapies, which I won't get into. So that's a strategy that's being used. There actually is a company called Elox Pharmaceuticals that has started a clinical trial, phase 2 study with their compound, their read-through inhibitor plus ivacaftor. Unfortunately, at least their early study suggests that although it was safe, it didn't really impact lung function at all in the patients that were treating it. So it's a little bit back to the drawing board for this particular medication. One concern is that perhaps the dosing was not optimal and that they can increase the dose. And then there may be some other things that they can do to help with that. So does anybody have any questions on that? Not right now. Okay. So so another therapy are splice mutations. So this is a very simplified drawing of splicing. So just one intron, 2 exons. Obviously, there's more than that in the real CFTR. But what a splice mutation does is it introduces a false splice site somewhere. So in this case, I'm showing one that's kind of farther up the intron than it should be. So it should be here, but it's actually here. And so what happens is when you do the splicing, you're splicing out too little of the intron and you wind up with this intron fragment. And because it's kind of random sequence, it often generates a stop codon or some other thing that messes it up. And you wind up with a truncated and non-functional CFTR. So there are these therapies called antisense oligos or ASOs that can actually go in. They're little segments of RNA or DNA, and they can bind to and kind of block this incorrect splice site. And so as a result, the body will then now use the correct splice site, get rid of that intron fragment, get your full length mRNA and your normal CFTR. And so this sounds like, oh, super cool, probably works in the lab, but this is actually a therapy that is being used, not for CF yet, but for a disease called spinal muscular atrophy. So the drug's called Spinraza. Some of you may have heard of this. And it's just super clever and a little bit probably too complicated to explain here, but it actually causes an exon that would not normally be included to get included into a gene that then sort of makes up for the fact that the SMN, which is the gene that's wrong in SMA, is missing. And so, and it's like miraculous. So these kids typically with the infantile version, they'll die before they're 2 years of age. And before they die, they are like almost completely paralyzed or super weak on a ventilator and everything. And now these kids are like walking around. So it's amazing what this is doing. So this is not CF, but it really, I think, gives us a lot of hope that this approach can be used. And there are companies doing this. So there's one called Spliceense, and they actually have 4 antisense oligos in preclinical testing. So 2 are for traditional splice mutations, and 2 of them are actually a little different. So what they're doing is they're actually trying to splice out an exon that has another mutation in it. And because of the structure of that particular exon, you can still get a reasonable CFTR. Maybe you need modulators or something on top of that, but at least gives you hope of getting something more functional. And so they were, I think, originally planning to start trials at the end of this year. I think more realistically now, it'll be the beginning of next year where they'll start their phase 1, phase 2 trials, which are the early stage clinical trials. So those are really cool, but of course, they're very specific to certain mutations. So what about genetic therapies, right? So that in some ways is kind of the holy grail of CF research, because a genetic therapy could work on everyone. It wouldn't matter what CFTR mutation you have, they would work. And at least some options, if they can give you permanent or semi-permanent expression, could be considered a real honest to God cure for CF. But this has been something that we've been going for a very long time. I think the joke in the field is that gene therapy is always 10 years away, no matter when you go. So, and there have been lots and lots of efforts. So in the 90s, we used what was called adenovirus to try to deliver the gene, and that didn't seem to work. Then there are these adeno-associated viruses that were a little better. They're not quite as, they don't cause as much disease as adenovirus, but those approaches didn't really work either. In the 2010s, there was this big study to try to identify the best vector to get your gene into the cell, and they landed on liposomes, which are these little sort of fat globules that can pull genes into the cell. But it turns out those didn't really work either. So unfortunately, sort of this long string of lots of trials without a lot of success with gene therapy. But there are still a lot of active approaches. And in fact, we broadened what we're doing in terms of looking at genetic therapies. So there are still traditional, what are being called gene transfer therapy. So this was what most people would think of as genetic therapy. So, and the idea here is that we've learned a lot about the different viruses and liposome vectors, and we think we understand why some of those failed before. And so we're making them better to try to actually get them to work. So there's that one kind of traditional way of doing it. Then there's something called gene editing. So many of you have probably heard of this. This would be CRISPR-Cas9. It got into the news a lot, certainly several years ago. And so these are enzymes that can actually go in and fix or change DNA in situ, meaning in the cell itself. And so there are ways to try to package up these molecules and deliver them to the cell, and then hope that it will actually fix the DNA of CFTR right in the cell itself. Then there are stem cells. So this is an interesting approach. So rather than try to fix the cells in the lung, which is actually pretty hard to do, you actually take cells from outside the body. In fact, you take blood cells, and then there are ways to take blood cells and turn them into airway cells. And you can fix them in the lab, which is much easier than trying to fix them in an airway. So you fix it in culture, you make them into airway cells, and then what you need to do is basically put the airway cells back into the lung. And that usually involves doing some kind of damage to the airway to kind of get rid of some of the existing cells and putting your new stem cells in there where they can engraft and kind of take over. So this is an exciting approach, but still probably pretty early in the preclinical stage. And then the last strategy that's being employed is directly delivering mRNA. So forget about correcting the gene, forget about trying to get all that to work. Let's just give the mRNA for the CFTR, put it right in the cell and have it work. And if that sounds familiar to you at all, it's because that's how COVID vaccines work. So they deliver an mRNA into the cell makes virus proteins, you recognize it as not as foreign, and you make a immune response to it. So you can do the same kind of thing with CFTR. Obviously, you want your CFTR mRNA to hang out a little longer than a vaccine mRNA, but the basic concept is the same. And of course, we know that mRNA vaccines work. So the basic idea of it is proven. So there's lots of companies that are doing this right now. There's one 4DMT that is actually now in human trials, phase 1-2 trials, very small trials, and they're kind of more of a traditional approach. They're using a adeno-associated virus. So one of the things that we've used before, but of course, they figured out some different approaches to try to make this work better than the previous versions that did not work. And they've reported a little bit of data. Really, it's, I think, just on 3 patients, but what they're saying is they can actually see gene expression in the airways of these patients after they delivered their vector. So that's promising, but still very, very early. The rest of these companies are still pretty much at the preclinical stage, but many of them are probably going to go into early phase 1, phase 2 trials in 2023. And they're all over the board in terms of their approach, mRNA and parvovirus and gene transfer and different techniques to edit or fix. So, it's really, there's a lot of shots on goal here, and hopefully one or more of these will actually pan out and become an effective therapy. But unfortunately, I don't think these are like right around the corner. We're probably, even in best case scenario, we're probably several years away. So there's lots of other drugs in the pipeline. So I've really focused a lot on the ones that are to restore CFTR function. So these would be the modulators or the gene therapies. I think one thing to remember is it looks great, and we're very excited to see this, but only about 1 drug in 3 that makes it into early clinical trials actually becomes an approved drug. So a lot of these things will fade out. In fact, if you go back to previous versions of this graph, you'll see a lot of drugs that aren't on the list anymore because they failed at some point along the line. But it's always nice to see that, even if it's 1 in 3, we've got so many chances that there's a good possibility that one of these will pan out. So what does it all mean? So if your child or loved one is modulator eligible, I think things that you would expect to see over the next few years are you're going to see the modulators approved at earlier and earlier ages. So 2 to 5 probably coming up in the next 6 months. They're already doing the 1 to 2 trial, and probably ultimately will get down into infancy for Trikafta. There is evidence now that what we've traditionally always told kids to do and adults to do who have CF in terms of pulmozyme and hypertonic saline and these other therapies, you may not have to do all of that. And I found that a lot of my families really value the idea of getting some of their time back and their life back in terms of not having to do these all the time. So it still needs to be an individual decision. So I would strongly advise you to talk to your CF care provider about how to approach this. But I think it's realistic to consider doing that if you haven't done it already, which some of my patients already have. And that we're going to get a lot more information about what it's like to have CF and be on Trikafta. And it's not going to be monolithic. Different people are going to have different responses, but we're going to have better ideas of how we treat you, what we need to watch out for, ways to address side effects and things like that. So that's all coming down the line. So what if your child or loved one is not modulator eligible, at least not right now? So we're still, I didn't talk much about this, but there's still a ton of therapies that are being developed to treat the symptomatic complications of CF. So new antibiotics, new agents to improve mucociliary clearance, new anti-inflammatory agents. So these will be coming, and they will continue our ongoing progress. And we were doing much better with CF even before we had modulator therapy, and that success is going to continue. I do anticipate, maybe not in the next couple of years, but somewhere down the line, we're going to have expanded modulator indications. So we're going to test whether modulators are effective for new genotypes that weren't part of the original FDA approval. And then a lot of these more mutation-specific therapies. So the read-through agents for nonsense mutations, the ASOs for splice mutations, and other things along those lines. And then ultimately, there's a lot of genetic therapies that seem very promising. Gene therapy has been successful in a number of other conditions. And so that wasn't true 10 years ago. And so that really gives a lot of hope that we can eventually get this working for CF, but I think it's still a few years away. So just to summarize this sort of introductory part, I think, this has been a period of unprecedented improvements to CF treatment, but we still have challenges that remain to get patients with CF to a normal state of health. We need to better understand what the modulators are doing and continue to develop other supportive therapies. And then, of course, the ultimate goal is curative therapy for everyone. And we're expecting innovative approaches from our research community to get there. But of course, we still need support as researchers to be able to do that, both from the foundation and NIH and other agencies. So that's all I have as a formal presentation. Stop share. But there was a ton that went on at the CF conference, and if for those of you who have been before, you probably know I didn't see all of it because it's impossible. There's so many things going on simultaneously, but I'd love to entertain any questions, comments, thoughts about this or anything else related to the state of CF research.
I just have a question whether there's been studies for in place for females for their pregnancies and stuff, but with Trikafta, has there anything been looked at as far as males being able to, their fertility improvements?
Right. So not as much. We're less optimistic for males who are older and have developed infertility in terms of because the males are infertile in CF because the vas deferens, which is the tube that connects the testes to the penis, right, doesn't form, or rather it probably forms and it involutes. And so it's just not there. And so starting Trikafta later in life is probably not going to make that come back. Now, of course, the sperm is still there. So there are in vitro methods you can use to actually get that sperm, kind of make it what we call competent to fertilize. And so it is possible for males with CF to have their own genetic children. What is interesting, though, is so there have been a couple of moms who were on Trikafta that wound up having babies that had CF. And at least one of those was a male and had a vas deferens, I think on one side is what the case report was. So this idea of treating babies in utero with Trikafta is really starting to emerge. There's been one case report, and I just heard about another mom. There was a mom that didn't have CF that was treated with Trikafta because the prenatal ultrasound showed a child with meconium ileus and looked obvious CF features, and that got much better. And there's a mom now that is taking CF, doesn't have CF, but is taking Trikafta just to see if she can get enough in her breast milk to help her baby, because it's not approved for babies yet, right? I don't know how they're getting these approved for these moms that don't actually have a CF diagnosis, but they're managing. So it's really exciting. I do think at some point it's going to become really important to do the genetic testing for risk for having a child with CF, because you may well, as a mom, choose to take Trikafta during pregnancy, because these kids are coming out and they're not newborn screen positive, right? So they're not showing up as CF. You have to look to find out. But then unfortunately what happens then is once they get past the breastfeeding stage, they're not getting Trikafta anymore, because we don't even have it. At this point, the earliest age we're going to get it is age 2, unless you get a special dispensation from your insurance company. So, eventually, hopefully we'll have it so that if you treat a child in utero with CF with Trikafta, that you can continue that right after birth, because so we have measured, so our lab actually measures Trikafta levels. And so we've measured it in breast milk, and it's definitely, it's there, it's low, and we've seen it. And we did a study with Aaron Trimble, who was a former adult fellow here, is now at Oregon. And we measured it in the babies that were on breast milk for moms that were on Trikafta. And we could detect measurable concentrations, much lower than what you would get if you were taking it yourself, but it's there.
Okay.
And one sort of related thing that I didn't mention, but I think is really interesting, is pancreatic function. So if you had asked me 5 years ago about pancreatic function in patients with CF on Trikafta, I would have said, well, I think the pancreas is gone. I don't know that there's much hope. And I would have been wrong, because we are seeing pancreatic function come back, probably more often in the younger kids that get started on therapy earlier, but even in some older kids. And so, there's at least some hope that with longer, and this probably could take a while, but with longer term therapy with Trikafta, you might actually see some gains in pancreatic function. We definitely see changes in the GI system with Trikafta, both good and bad. But
yeah, with the new therapies that are coming out, I mean, if Trikafta is improving their lives already, would it even be worth changing to something new if it's already improving your life?
Yeah, well, there were a lot of companies in the field, and many of them, I think, backed out because they were like, what, for that reason, they're like, who's going to want to switch? So there are people who have side effects to Trikafta. So probably the biggest ones are liver. So we have I personally don't have any patients myself, but there are some patients in our center that I had to stop. Certainly a lot have had to modify their Trikafta dose based on liver, and a few that have had to stop. And then mental health issues have been another one. So we've had a few patients that have had to stop Trikafta just because of anxiety or depression or something else, and that we feel is probably related to the medication. This is a really growing field, and it's kind of hard to know. And the fact that this all came out with the pandemic and there were all kinds of mental health issues related to that doesn't help us figure things out. But there's enough smoke here that I think there's a fire. And so at least some people don't feel like they can take Trikafta even if they're eligible. And so a new modulator might be helpful for someone like that. And it may be that some of these other mutations like N1303K or, that are still folding mutations, but aren't as Trikafta responsive, may respond better to other drugs. But it's hard to imagine for most people that there'll be a significantly better therapy than Trikafta if you're for the eligible genotypes.
Yeah. I know for my son, one of the major improvements he's had is he has now his nose. He's had polyps removed twice. His nose is like normal nose.
Yeah.
He no longer has the polyps in his nose.
Yeah, I have a lot of
throat.
patients where I have their their sinus history in my note, and I keep carrying it forward, but I'm like, I don't even know that I need to do this anymore, because there was a study that was, I think it was called CF Snot,
Yes.
where they looked at polyps and sinus symptoms before and after Trikafta. I'm not sure if it was formally part of the PROMISE group or sort of an ancillary piece, but a very similar thing. And again, the pandemic made everything a lot harder. And so I don't think they got the enrollment that they wanted, but they generally saw effects similar to what you saw in your son, which is fewer polyps, improved sinus disease. So yeah, we're really hopeful that will be that will be true for the population.
You said that the pancreas, you said was pretty much beat up from CF. Is there any hope that it would also reduce the incidence of CF related diabetes?
Yeah, so that's you know, the short answer is, of course, we don't know yet because we're going to need longer term. There is an endocrine piece of the CF Promise studies, and they had a poster at NACFC, and they did actually show some improvement in glycemic indices of people that already had CFRD. So hemoglobin A1C was a little bit better. Can't remember what else there was something else that they showed that I don't recall. It's hard to know if that's an actual improvement on the diabetes itself, or just, you know, less inflammation and infection, making it easier to control existing diabetes. But, you know, we're certainly hopeful. You know, one would, you know, CF-related diabetes is felt to be, you know, the beta cells, which are the insulin-producing cells in the pancreas, as being kind of innocent bystanders, right? So the pancreatic enzymes get stuck in the pancreas because the ducts are closed off, and they eventually leak out and start destroying everything around them, and the beta cells just get caught in the crossfire, so to speak. So the hope would be that with Trikafta or a similar modulator therapy, you're opening up those pancreatic ducts, and so the enzymes aren't sticking around where they're not supposed to be, and hopefully won't be killing beta cells. But so that's the theory. Whether that's going to be true in practice, we don't know yet. But that we're obviously hopeful that will be the case. And we know this is your trivia. You guys all may already know this, but you know the full name of cystic fibrosis, right? It's cystic fibrosis of the pancreas. The disease is named after the pathology in the pancreas, not the lung. Even though it sounds pretty appropriate for the lung, right? But yeah, back in the, I think it was it the 30s or the 50s, a pathologist first described it as, and that's where the name came from.
Because they were all failures to thrive because they couldn't.
Right, they were all failure to thrive, and there was another
nutrition
condition called Shwachman-Diamond syndrome, which was another pancreatic insufficiency syndrome. And so she was trying to distinguish what she called cystic fibrosis from that. And that's where the name came from, and that's what stuck. Any other questions, thoughts?
That's all I had.
I think my husband has a question, but he's taking the dog out right now. Oh. Sorry. Can you hear me now?
I can hear you.
Okay. I think my husband has a question, but he's taking the dog out. But I have a question, because I think both my daughters take Trikafta, and but I do think that they both have some mental health side effects, and we've dealt with that. But how are you going to determine whether that was, you know, directly related to the Trikafta versus all the other, you know, variables like the pandemic and everything? Because the timing was, you know, did it, you know, coincide with that?
Yeah, it is going to be a challenge. And we, at this point, we don't really know enough. I don't know if you guys know who Rick Boucher is. He's the head of the Marskilling Institute, used to be called the CF Pulmonary Research Center. And he was at the CF conference, and he's like, we got to measure Trikafta levels in the brain. So, because one of the things my lab does is measure Trikafta levels. And so we're really keen to try to figure out what's going on and how this might be happening. In the meantime, we are certainly open to trying things like dose reduction. The pharmacology of these compounds is actually really interesting. They tend to build up in cells, and you know, we've done some studies suggesting that the typical clinical doses, which were really designed based on cell culture experiments, you know, may not necessarily be the ideal mix of benefit versus risk And so it may well be that lower doses will be effective if it builds up in the right cells. And so we've definitely been open to doing that. We can't, so the lab, the stuff that I do, for example, is not meant for clinic. So like our lab is not what they call CLIA certified, meaning that we're certified to give you results that you can then use to make clinical decisions. But they're the lab at National Jewish is close, if not already able to measure the levels. And so we don't know that the concentrations of the Trikafta molecules correlate with the risk of mental health issues, but at least it would be something hopefully in the near future that we could measure and just at least know kind of where you're starting from and try to figure out from there, like, well, you know, if your levels are really high, you know, higher than the typical, you know, maybe we can dose reduce and we can see what that does and see if that helps with the mental health issues. We're actually doing a study now with Cameron McKenzie and Carissa Cam and our pharmacists where we're doing pharmacogenomics. So we're actually looking at genes that we know influence the how you metabolize drugs. And then we're going to measure Trikafta levels and see if there's a correlation. So we could at least, if that shows us something, we could at least measure your genes or your kids' genes and just say, hey, you're at risk for having high levels of Trikafta because you don't have your metabolizing enzymes aren't as effective or something along those lines. Or maybe your metabolizing enzymes are too effective and so your Trikafta levels will be low, and we might be able to sort of dose adjust on an individual basis by knowing what your genotype is.
Okay, so both my daughters are seen in the adult clinic now, so this would sort of be up to them to ask about. So would this be something that you see maybe clinics doing on a standardized basis, or it would be dependent upon those patients to say something? Because I'm not sure my daughters would say something about it.
Yeah, I think the adult and pediatric pharmacists talk a lot. And so they are starting to develop kind of standard approaches to dose reduction and just saying, you know, what do we do? Like, oh, you stop taking the orange pill or you take only one of the blue pills or something like that. So some people have flipped them too. That's the other thing that I've heard is, is it blue in the morning and orange at night? Or do I have that backwards?
I think it's the other way around.
All right, orange in the morning and blue at night. Okay, so you flip them. Right. So you do the morning one in the evening and so that's for people where they're having sleep issues or things like that. That seems to have helped some people. So there's different strategies, and we're going to, that's definitely an area where we need to focus and learn more.
Okay, thanks.
Are some people having a lot of issues with sleep as far as being on Trikafta?
Yeah, what I should say is I have heard people in our group say that they've seen that. And I think they've seen it on the pharmacy boards as well. I haven't had, I have one kid that I think might be having trouble with sleep, but also anxiety. But I think it's being seen. It's definitely out there and there's enough of it. We don't have anything, it wasn't seen in the clinical trials, or at least it wasn't reported out as such in the clinical trials. And I don't think, I have to go back to look at PROMISE to see how well they were looking at this, but I think they were looking at mental health, but I don't know that data is out yet. There's still a lot of PROMISE data that's not been published yet. But there's enough anecdotal evidence that I think most CF providers believe it's real, at least for a subset of patients.
Yeah, my son's been on Trikafta about a year, and it's lately, like at the last month, he eats dinner, then he goes and he has his Trikafta with dinner, then he goes to sleep for like a while before he gets up and then does some more activity. So I was just wondering whether that was a thing.
Yeah, I mean, sleep disturbances, I'm not sure if I've heard as many people that fall asleep right away. I think I've heard of more people that have trouble sleeping. But again, I think there's been enough anecdotal reports of sleep issues that we would at least consider the possibility that this could be Trikafta related.
Interesting.
But definitely something to talk to his doctor about, especially the flipping doses. Like if that doesn't happen in the morning, maybe it's hard to say.
Interesting.
Although the morning pill is the one that has all 3 drugs, and the evening pill just has ivacaftor. So you wouldn't think that would work for someone who falls asleep with pure ivacaftor, because you'd be getting, because ivacaftor is in the morning pill too. But you just never know. As a physician, you learn not to say never, because just individuals are unique, and you can never rule out any particular effect or side effect or unique reaction to something. So
could be just that he just games too late at night.
yeah, and I mean, I tend to drink a glass of wine with dinner, and I often fall asleep after dinner as well, but and I'm not on Trikafta. So but I think I know what that is.
I have another question.
Sure.
You had mentioned that the Trikafta has had some mixed reactions in the gut, I think.
Mm-hmm.
And I was just wondering I don't know, if you could speak a little bit more about that.
Yeah, this is more anecdotal than what I've seen in the literature. So certainly in the literature, overall, people have significant increases in weight and BMI. We've seen a lot of just abdominal discomfort, constipation. We've had to adjust enzyme doses both up and down for a lot of patients. A few that have really had significant GI issues. I mean, I've had a couple of patients that have actually, been hospitalized for abdominal pain and cleanouts since starting Trikafta. So I don't know. I would have predicted that the gut would get much better, because there's a lot of mucus in the gut, and I think we under recognize how much of a contribution that is in CF. And I thought Trikafta would make that all better, but it's not as simple as that. And so certainly abdominal discomfort, pain, bloating, constipation, we've had few patients that seem to be struggling more with that on Trikafta than they were before. And I don't have a great explanation for that, but I just anecdotally, we see it, and we're trying to manage it.
Okay, thanks.
Any other questions or?
I have a question. With the Simplify study, you were saying that they were studying hypertonic and pulmozyme. Was there anything that was studying other medications they could come off? Because at one point I thought I read that they were also studying about kids that could come off enzymes completely and things like that. So I was just wondering what other things besides the hypertonic.
Yeah. So Simplify was just pulmozyme and hypertonic saline. So there were 4 groups, and you were on or off hypertonic or on or off pulmozyme. Promise, I know, is looking at pancreatic function, and we've been looking at pancreatic function and definitely seeing, at least there are some patients that are regaining it. I don't know. I think we're probably more at the stage of, are people regaining pancreatic function? And then of course, individually, if you see that, you start backing off. I don't know if we're at the point where we're starting to routinely say, oh, can we take patients off enzymes, like a Simplify for enzymes? I don't think there's anything like that going on, but we're asking for poop. So I don't know if you've, if you come to the Chapel Pete's clinic, we're going to watch your poop at some point.
Yeah, my oldest is 9, and she has been in the Promise study, but she's in the maintenance phase. She was a year in the summer, so she's in the maintenance phase now. And my little guy will start Trikafta this month. He turns 6 this month, so we're getting close.
That's very exciting, isn't it?
Yeah.
Yeah, so I think we're going to know more. I suspect it's going to be somewhat individualized. It's going to depend on how much structural damage to your pancreas you have. And then what we don't know is, how much regenerative capacity the pancreas has. Like, can it grow back? I would have said, I don't think so, but I don't know the answer to that now. I'm a little more humble and saying, well, we're going to have to see what happens. So we're definitely, we're monitoring for GI stuff, and then we are testing poop. And we've had a few people that we've either backed off or even stopped enzymes because their pancreatic function appears to have come back, which they love. So.
Were those in younger patients?
So mostly younger, but some that were older. So Cameron was showing me some of that data, and I think we had some older kids that regained some pancreatic function. So we haven't looked at it like in depth to kind of look at the patterns to know for sure. I suspect that people that had like a little bit of residual function, like a measurable level of fecal elastase, but not enough, were more likely to sort of regain function. But I don't actually know that for sure. And I mean, the other piece that I would say is that it was 2019 for 12 and up. So we are at best 3 years into this. We don't know what 10 years of Trikafta is going to do. And I'm more cautiously optimistic now about pancreas than I would have been before, just because I think we're seeing more of an effect that I would have predicted. And it makes me at least cautiously optimistic that maybe people that I would have been like, no, you're 25, your pancreas is done. Maybe with a long course of Trikafta, they're going to start regaining some function. I mean, maybe it won't be complete. Maybe it'll be a little bit, but enough to reduce enzyme doses, or, if you skip it, it's not going to be quite the same consequences. And then, Chris, the diabetes question is unknown and probably won't be known for years, but, there's reason for hope.
Thank you. Does anyone else have a question? I really appreciate your speaking to us tonight.
Oh, I'm happy to do it. My patients will know I love to talk in clinic, so. Well, great. Well, if any questions come up, if you let Ellen or one of the organizers know, I'm obviously happy to chat by email or something like that. If there's something that either you didn't feel comfortable asking on the Zoom or comes up later on. So, but other than that, I guess if no one else has any other questions, I'll let people go.
Thank you so much.
All right. Well, thanks for coming.
Thank you.